Hi, my name is Ashley Edgewan, and I'm a 10th grader at Andover from Queens, New York. Also, as just a warning for this presentation, there will be an interactive question where you will need a device in order to answer. Um, yeah. When I first started working on this presentation, I was interested in racial disparities in healthcare, and in my research, implicit bias kept coming up. So I decided to do more in-depth research about it and how it affects health disparities, and it led to my topic now. Um, so this is a part where you, the audience, can interact with the presentation. I wanted to ask you what you already know about implicit bias. So if you would like to answer the question, please use the device to go to menti.com and use the code. I will be sharing responses on the screen for around 2 to 3 minutes, but your answers will be anonymous. So I will share the code in the chat so it's easier to copy and paste it. Yeah, so implicit bias is prejudicial thinking that goes largely acknowledged. Um, it's like not conscious. So yeah, there are tests conducted to check how much bias you have. There is one hosted on, I think, Harvard's website. Yeah, we do have all some form of it. Okay, so let's go back to the presentation. Thank you for your responses. So implicit bias is prejudice in favor or against a person or group compared with another person or group, usually in a way to be considered unfair. It's present but not consciously held or recognized, and it can be related to different things such as age, class, and gender. However, this presentation's focus will be on race. So the theory of Everest of racism, which is defined by theory developers Samuel L. Gartner, PhD, and John F. DeVito, PhD, as people who consciously advocate egalitarian beliefs but subconsciously have negative feelings toward people of color. They said that people may hold negative unconscious beliefs about others that are different from their conscious feelings, which is known as implicit bias. In 2003, Unequal Treatment, which was a report from the Institute of Medicine panel, which is made up of behavior scientists, physicians, public health experts, and other health professionals, concluded that when access to care barriers such as insurance and family income were controlled, BIPOC people received worse health care than white patients, and that implicit and explicit bias was the reason. And so, how is implicit bias measured? The main measure to assess implicit bias is the Implicit Association Test, IAT. In 1995, Anthony G. Greenwald, PhD, who was and is a psychology professor at the University of Washington, created the IAT. The test measures the strength of associations between concepts and evaluations, like good or bad or stereotypes. The test tries to analyze and dig out people's initial responses and potentially their subconscious mind. So this is an example of a question on an implicit bias test. On a race-based implicit bias test like this one, you have to use two keys on your keyboard to identify a series of faces that flash on the screen as black or white and a series of words that flash on the screen as good or bad. Then the test mixes up the categories, but you'll still have two buttons. For example, if you have a slow reaction when selecting good, when black is linked to it, then it's red as you have a bias against Black people. So according to the Hospital of Special Surgery, HSS, there has been an increase in reports of bias, explicit and implicit, with the spread of COVID-19. Ideas about a patient made because of unconscious associations rather than that person's individuality can lead to poor care. Unconscious bias is problematic because people are unaware that they have a preference for or against people based on factors such as race. The theory of implicit bias was created in the 70s, and the test was created in 1995. But even in the present, there are still increasing reports of implicit bias. And individual words that doctors use can indicate implicit bias. According to Nao Hajiwara, PhD at Virginia Commonwealth University, doctors' tendency to use first-person plural pronouns when interacting with Black patients is connected to people using it to maintain control over others of lesser power. She also found that doctors who scored higher in implicit bias spoke more of these words than coworkers that scored lower in implicit bias. This includes using language such as, "We're going to take our medicine, right?" Many times, implicit bias comes out in stressful situations or circumstances where people are multitasking. Doctors are dealing with people who are frightened and reactive, so they have to instantaneously react. So they're trained to think fast and be confident in their decisions. This leads to treatments prescribed on instant judgments and internalized stereotypes surface. In a study of Black cancer patients and their doctors, providers high in implicit bias were less supportive and spent less time with their patients than doctors low in implicit bias. Patients had a hard time remembering what their doctors told them and had less confidence in their treatment plans and thought it would be harder to follow recommended treatments. In a study where researchers asked patients and doctors about their race-related attitudes, video recorded them during the appointment, and measures doctors' implicit bias, it was found that Black patients felt most negatively towards doctors who were low in explicit bias but high in implicit. So this is an example of a story of a patient of color experiencing bias from her doctors while trying to get treatment from COVID-19. According to NPR, in the middle of March 2020, Carla Monteroso fell sick with the symptoms of COVID-19, but she wasn't sure she should go to the hospital because she said, as a woman of color, she's Latina, she gets questioned a lot about her emotions and the truth of her physical state. And she gets called an exaggerator and a lot in prior experiences. So it took 4 friends for her to call 911 and go to the hospital. During her time in the emergency room, healthcare providers dismissed and ignored her concerns and symptoms. For example, her low blood pressure was called a false reading, and the shooting pains in her leg were called a cyst. In May, Monteroso was having trouble breathing and feeling dizzy, so she called her friends and her friend's cousin, who was a cardiac nurse, for help. They began asking questions to the doctor, but the doctor walked out of the room and refused to care for her while her friends were on the phone. When the doctor came back, all he wanted to talk about was her tone and her friends. She advocated for herself and told the doctor that she wanted to talk about her symptoms and the possible blood clots in her leg and requested a CT scan. The doctor refused and said that the CT scan is right next to her breast tissue. So he's only giving her a CT scan if she's comfortable with getting breast cancer. So she says she's fine getting breast cancer so she can get the test, but he never ordered it. She asked for a different doctor and for a hospital advocate, but she was told no. Her friends called all the healthcare professionals they knew to confirm that the treatment that she was getting was not okay. They took her to another hospital and she received an EKG, a chest scan, and a CT scan. She says, quote unquote, because when we go and seek care, if we're advocating for ourselves, we can be treated as insubordinate. And if we're not advocating for ourselves, we can be treated as invisible. Her story is an example of and contributes to why the racial disparities of COVID-19 health outcomes are so large. So these are some potential solutions. While the IAT is one of the main ways to measure implicit bias, there are many problems with the test. According to Vox, it requires a collection of results before the test can make any actual conclusions. Taking one test is not enough to predict the behavior of a person. Additionally, the test is impacted by explicit attitudes. For example, the results are influenced by people's desires to create a good impression. Another possible solution is using available data to address disparities and gaps, conducting analysis from the data to make sure if the proposals and the approaches that have been put into place work and if they're addressing the disparities. In addition, reforming the training and curriculum. In medical school, students should continuously learn about health inequities and implicit bias instead of in isolated cases. This makes it more emphasized and hopefully challenges students about their own biases and how it may pass on to the treatments of their patients. Through my investigation, these solutions came to mind, but I wanted to get answers from healthcare workers, so I interviewed 3 prep alums who are in the healthcare field, and this is what they had to say. So this is Ebony Easley, who is an MPH.
If there's a 16-year-old woman in a one-on-one appointment with a doctor, and that doctor is saying like, no, I'm not giving you this. I don't give this to people who are young. There really isn't anything that person can do, right? Like, what is that 16-year-old woman supposed to do? Is she supposed to say like, no, you must? No, the doctor has all of the power in that situation, and can say like, I'm not treating you. I'm not treating you. And that's the end of the interaction. So I think that it's really up to people like me who work in supporting public health systems, to create an enabling environment so that those situations don't occur. There is some work to be done in like we call it pre-service training, like in medical school, or when doctors are in residency, in order to ensure that like they're challenged in their beliefs. And so, you know, when you are in medical school and you're learning about pain and pain management, that those students are taught to understand pain as something that happens across the board, and that it's not different based on who is sitting in front of you, and that there could be some sort of more objective metrics to use when assessing pain, as opposed to just whatever the provider feels is right. And so that is one thing. And I think that also in some of the training that happens in residency, again, having attendings who are able to support and teach, you know, new doctors about that and to challenge them when they see it happening. Like, why did you prescribe this for this patient and not for this one? Tell me, like, objectively, tell me about this person's medical history, about the way they're presenting, and why did that lead you to make one decision and not the other? I also work a lot in data. So I do think that like looking at data, just like the kind of data I was just talking about, right? To say, look, at our hospital, when patients of color are prescribed XYZ at this rate, and white patients are prescribed XYZ at this rate, like what are we seeing in the differences here? Or we made these diagnoses here for this group of people and not for this group of people, right? Like that, I think that there is a lot of power in taking time to look at what data is telling us, because I think that can tell a story that can uncover biases and can point us in the right direction of where we should be working. So I think that some of those are things that can be done.
And this is Bessel Abrahanu, who's a third-year medical student at Mount Sinai School of Medicine.
I think it's challenging because I think a lot of times this weird paternalistic dynamic is set up with physicians and their patients. And like, sure, clinicians have gone to school and have trained, but ultimately you as the patient are an expert on yourself and your health. And if something's different, if you're in pain, if something's wrong. So don't allow someone's perception of you to determine what kind of treatment you get. I know it can be really difficult from the patient side. There's been times where my complaints have not been taken seriously. And I just was like, I can't deal with this. I don't want to follow up and like cause a fuss. But your health is so important, right? It's like something that once it's compromised, it's really difficult to get back on track. So don't be afraid to get a second opinion. Don't be afraid to ask for documents. Even if you feel like there's a concept that your physician's explaining, but you're not really understanding it. I'm a big believer in teaching across the relationship and the dynamic between providers and patients. So don't be afraid to ask questions. Like, the physician is there to take care of you. Ultimately, we are in service of patients. So if there's something you feel like is important to you that's not being addressed, don't be afraid to say something. And I think ultimately for prep students, I'm obviously biased, but I think the more Black and brown and diverse voices we get in medicine, the less likely we are to have these issues keep on popping up.
And this is Denzel Harris, who is a doctor, internal medicine.
So patients have a lot of different ways that they can not just advocate for themselves, but protect themselves in the context of concerns about bias. Of course, it's tough. I can't say enough that being in the vulnerable state that you are in as a patient, it can definitely play a role in how you see yourself in relation to the people that are taking care of you. But I think first things first, patients can say something directly to their care teams, whether it's directly to the nurse, to their physician, to whoever is interacting with them, just saying, hey, I had, a not good experience or, a negative encounter with someone, which would then allow for a conversation to be had about what they experienced and about, what, could be done about that. For one example is I've had conversations in the past with patients who felt that, they weren't getting the best care that they deserved. And, my way of advocating for them, not just listening to them and taking in their concerns, was to inform them about, patient advocacy office in the hospital, and making sure that they knew that they had that means outside of the care team to speak with someone that could address their concerns. Of course, patients oftentimes come into the hospitals and they have family that can advocate for them. This is especially true for patients who may not, be in the right state of mind or maybe too sick to advocate for themselves. So, that's another major way that, we can have people advocate for themselves or on their behalf. So I'd say that those are, some of the few ways in the midst of a lot of other things that can be done to help protect people.
And like Ms. Aisley and Dr. Harris said, doctors do hold power over the patients, but physicians do not know everything. And like Ms. Bahano said, the patients know their bodies the best. At the end of the day, like Ms. Aisley said, it is up to public health professionals in order to help create environments where these situations do not occur. So thank you. I would like to thank thank you to my alum mentor, Ms. Zara, for her support and feedback throughout the process, Ms. Solomon and Mr. O'Leary. I also like to thank the interviewees for their thoughtful and helpful answers and suggestions. And I would like to thank my family for allowing me to present in front of them millions of times. And lastly, I would like to thank you, the audience, for engaging in this presentation.